So good afternoon, everyone. I know it's been a very long second half of a week, and we appreciate those of us who've been with us during this period. We also want to welcome those who have come specifically for the Globalfund Roundtable. Please feel welcome. I want to recognize our colleagues from the countries around us, our neighbors. So we have Ian Clark, if you could just so Ian Clark is the chair of the Uganda Healthcare Federation and also the current chair of the East African Healthcare Federation, which brings together 7 federations, country federations together. That is Kenya, Uganda, Tanzania, South Sudan, Rwanda, Burundi, and Ethiopia. So thank you very much for being here. Then we have Dr. Nazir from Tanzania. He's the director of the private sector federation as well. It's called Association of Private Health Facilities of Tanzania. And then we have Professor Kirti. He's invited guest from India, specialist in health management. He's also a visiting lecturer at the Strathmore University. And also he's invited here specifically to give best practices and learnings on medical tourism, which was one of the anchor, whatever. Then we have the colleagues from Southern Sudan. So we have, I will have to mention their names. So Emmanuel Togun, yeah, from private sector in South Sudan. Then we have Dr. Moses Deng, yeah, is he still with us? Oh, then we have Dr. Kidiende Chong, who has left. He had to catch a flight back. Thank you all for coming. Then we have Rita Namutembi. Rita from Uganda Healthcare Federation Secretariat. Rita, are you there? We have Mohamed Shukur from Addis Ababa. He's a vice president of Ethiopia private sector. Then we have Danny Mutembe. Danny is from Rwanda. He's a director of the Rwanda Healthcare Federation. We have Dr. Egina Makwabe. Dr. Egina Makwabe, I think they're still having lunch. He's the chair of the Private Sector Federation of Tanzania. And then we have Dr. Francis Mwanisi. Dr. Francis, are you there? Okay. He's representing the Ministry of Health. He's a registrar of the private health facilities in Tanzania. We have Dr. Samo Gilo, who has also been in another meeting. And we have Dawit Moges, who is the Secretary General of the Ethiopian Federation. Danny, if you could wave. Danny is from Rwanda Healthcare Federation, so private sector. We're just starting off our private sector roundtable. So I would like at this point to acknowledge and appreciate the Globalfund for making this possible so that we can have a discussion and a dialogue around what Globalfund does. In Kenya, for example, we have a country coordinating mechanism in which private sector is represented. A form of private sector is one of the constituencies that sit on the Kenya coordinating mechanism. I'm the alternate to the main representative, who is Daniela, who sits at the board of Kenya Healthcare Federation. And of course, present here, and most of the colleagues who have joined us this afternoon are primarily members of the Healthcare Federation, Kenya Healthcare Federation. So we welcome you, and we look forward to the deliberations. So I think as we have this dialogue, and I know Margaret will also, and Rosemary will also give us more perspective on that. We want to find out, we will be told about the stuff that's happening at Globalfund, but also as private sector, where can we plug in and a lot more, and especially strengthening, the resources around sourcing products and other stuff from the country. Are these the only solutions that we have? Does private sector have other aspects they can recommend as solutions for, the diseases that are focused for Globalfund, which is basically malaria, TB, and HIV, and of course, COVID-19. So without further ado, I want to welcome the next speaker, who is Margaret? Rosemary to take us through the presentation. So Rosemary She sits at the center of Globalfund, so ask her all the nice questions and the tough ones as well. Thank you.
Thank you so much, Dr. Nyalita, for the opportunity to be here and share this presentation. My name is Rosemary. I was here on day one as well in the opening plenary. I remember seeing many of you in that meeting. I am the executive director for Waki Health. Waki Health is an Africa regional advocacy organization, and we also host the Globalfund Advocates Network, Africa Hub. So it's a global network of advocates who support resource mobilization for the Globalfund, but also are very keen to look at the policies at the country level and make sure that grants at the country level are also impactful. This work, as Dr. Nyalita has mentioned, we have co-organized it also together with the Kenya Coordinating Mechanism Secretariat. So my colleague Margaret Mundia will also be joining us after the presentation as we look into having a conversation and a dialogue. So I will request the tech team to maybe project the slides. I will take us through a few slides. And as they do that, why we thought this session would be important, it's for many reasons. But I think one of the things we saw during COVID-19, when COVID-19 hit, one of the global agencies that was the first to respond rapidly, put money on the table, respond, support countries with resources to mitigate the impact of HIV, TB, and malaria at the country level was the Globalfund. But also, when you look at the conversation or the narrative around why Africa was able to respond to COVID-19 in the significant way we did as a continent, even though COVID-19 came when we were already, responding to HIV, TB, malaria for a long time. So you could say that our health systems are in a fragile state, and COVID-19, as a big threat is something that kept us awake at night. But the way our health systems were able to respond, even to a point where you could hear people saying what's happening in Africa. We expected Africa to burn down because of COVID-19. And I know there are many factors that contributed to that. But one of those factors is how the long-term investments by some of these global health institutions like the Globalfund for 20 years having invested here in health systems, in community health workers who can go to door and support with the delivery was very important feature. So this year is a very important year for the Globalfund because it's the replenishment year. Every 3 years, the Globalfund gets to be replenished so that then we can be sure to have funding for country level and granting. So if we can go to the next slide or the third slide, the other slide, because we won't go to every slide. But I think the first thing is to say the Globalfund has a new strategy. I know most of you have engaged with the Globalfund, but it's also evolving. The current Globalfund strategy framework will run from year 2023 to 2028. It still, as an institution, has kept its mandate of ending AIDS, TB, and malaria. So during the conversations and the discussions that led to this new strategy, there was a question of, should the Globalfund expand beyond AIDS, TB, and malaria? Should they think about, pandemics? Or where is it still a relevant mandate? And the mandate is relevant, and therefore it's still the primary goal of the Globalfund, but also very appreciative and intentional about its role as an institution to strengthen health systems and help in pandemic preparedness. So this is really the structure and what the Globalfund will be doing. And within, at the center of that, there is a huge intention to work with and to serve the health needs of people and communities. So you'll see within the new Globalfund strategy framework, putting people at the center, thinking about equity, thinking about people-centered integrated health systems for health to deliver impact, resilience, and sustainability, maximizing the engagement and leadership of most affected communities to leave no one behind, maximizing health equity, gender equality, and human rights. But beyond that also, there is this evolving objective of the Global Fund, which is to mobilize resources, increased resources for health, and also to contribute to pandemic preparedness and response. But also, the Global Fund is a partnership enabler. If you look at the Global Fund partnership model at the country level, it's a partnership model that has evolved over years. Those of you who have worked with the Global Fund for a long time, and it's been around for 20 years, you can attest to the fact that the Global Fund you see today has significantly changed from the Global Fund we saw 20 years ago. And it is the work. A lot of you in this room have worked either with governments, with private sector, with NGOs to actually support that model, which is really one of the best health financing model in global health. It can improve, but so far, we believe it's one of the best. If we could go to the next slide, please. This is really about the replenishment itself. Why the replenishment is important is because if we don't have the replenishment, it means that for all of our countries that are funded by the Global Fund, there will be no grants starting from 2024. So 2024, the grant cycle is a 3-year grant. So 2024, 2025, 2026. And that's why it's important for us to make sure that the replenishment of the fund is successful, because what that means is that we can get funding for grants implemented in 2024 to 2026. And so I think just in terms of a reflection, we do know, or we might have come across the information that in the previous replenishment, which was the 6th replenishment hosted by the government of France, and it was in Lyon, the Global Fund raised about 14 billion US dollars. This replenishment this year in September is going to be hosted by the US government in the US. And so the leadership of the hosting country, the leadership of the country that is supporting and hosting is very critical. What is very unique about this replenishment, the 7th replenishment, is that it is also being supported or co-hosted by 5 African governments. So we have the government of Kenya, South Africa, DRC, Rwanda, and Senegal. These are the 5 heads of state that came together to launch the replenishment campaign back in March. And this is important for us because we are implementing countries, and basically a lot of the resources and investments of the Global Fund are actually then being directed to our countries. And so having these African heads of state supporting, championing, and also co-hosting the replenishment is very important. And we'll see in the investment case that it's not just about the money that is coming from the Global Fund, but it is also the possibility we have with the Global Fund to catalyze some domestic resources, but also to expand partnerships with private sector. But first, I think if you go to the next slide, it's a question of what resources are needed. Maybe some would, yes, what resources are needed? Why 18 billion US dollars? This replenishment will be successful if we raise over 18 billion US dollars, a minimum of 18 billion dollars. And how we arrive at this, and when I say we, I mean the Global Fund partnership. So that's the Global Fund Secretariat, it's the governments at country level, it's civil society, everybody who is part of the Global Fund partnership has contributed to the strategy and to this number. So as a community of advocates who support and believe in the Global Fund, why 18 billion is because it takes into consideration the HIV, TB, and malaria global targets and global resource needs. If you put the global strategy and resource needs for HIV, TB, and malaria, it comes to about 130 billion US dollars. So that's the resource need, 130 billion US dollars for HIV, TB, and malaria. But the Global Fund is saying out of that 130 billion US dollars, we will host this replenishment to mobilize at least 18 billion US dollars. There is a slide that is not showing or projecting, not sure why, but what that slide shows is that out of the 130 billion US dollars that is a global resource need, the Global Fund replenishment will aim to give us 18 billion. But within the investment case, it also says that at the country level, we will be able to generate some domestic resources. Because you know how the Global Fund grants are done. There is a core financing, for example, the domestic resource mobilization commitment. And so when you put that together and when you put many other aspects, it is projected in the investment case that this 18 billion US dollars will spur 59 billion US dollars in domestic resources over the 3 years, 2024 to 2026. And so, and that's from implementing countries. Then from non-global fund, external funding, they are projecting to get about 25 billion US dollars. And if you do the math, there is still a gap of about 28 billion US dollars. So this is to say that the money that the Global Fund wants to raise, $18 billion, is to support. It's just a fraction of what is needed in order to respond or to invest in HIV, TB, and malaria globally. And so you can see that there is need for everybody to step in. There is need to ask questions, for example, how can we leverage the private sector? How can we make our services more efficient so that we can save? How can we cost save and make sure that we gain on efficiencies? If we go to the next slide, yes, so sorry. So I think we are losing some slides. It must be something. So this is not the slide I wanted. I wanted to speak to what will, so let's go back to the 18, the other slide, so that let's stay here. But I wanted to speak to, if we get $18 billion for the Global Fund replenishment, what will that give us in return? So the investment case has projected that it will save 20 million additional lives. Now remember, 20 years of Global Fund's impact, which last year was the 20th anniversary. So Global Fund being here for 20 years has so far helped to save 44 million lives. That's the projection, that's according to the latest report of the Global Fund, 44 million lives. So if we get 18 billion US dollars and we are able to provide grants to countries 2024 up to 2026, that can help save 20 million more lives. And what that will do is to help reduce the mortality rate by 64% by 2026. It would also help us to avert new infections. The projection in the investment case is that it would help us to avert about 450 million infections or cases. So reducing the incidence of cases by about 58% by 2026. And then the other thing with this 18 billion investment, it would help us in keeping the downward trajectory of the epidemics consistent with 2030 targets. So one thing we know is right now we are out of track to meeting the global goals on HIV, TB, malaria, and many other sustainable development goals. And so if we miss the opportunity to save these additional 20 million lives, reduce the incidence, etc., it means that we will be still out of track. But achieving this and investing and getting these returns, it will help us to keep the downward trajectory. But also, as mentioned, this investment would help in catalyzing of domestic investments up to 59 billion US dollars. That's the projection. But also approximately 6 billion would be available to reinforce systems for health, contributing to improved pandemic preparedness. So out of this 18 billion, about 6 billion would actually go straight into health systems and contribute to improve pandemic preparedness. Now, return on investment. I have no idea how the formula works out on return on investment, but as per the investment case, the return on investment is 1:31. So for every $1 you invest, you get $31 in return. And the last one is reducing between the country inequality in life expectancy by 9% by 2026. So this is the return on investment, basically what the 18 billion US dollars could buy us. So I don't know if we are able to see one more slide. If you could go to one more slide, Eric. If you could go to slide number 11, I don't know if it's visible. Number 11. So this should be slide number 11. So what are some of the things that we are doing or can be done in order to amplify these messages or this voice, because it's an important moment. So how do we amplify this movement? There are certain key opportunities, because to get to 18 billion US dollars, it's not something that is given. We really have to advocate for it. We have to push for it. It is the donor countries that put most of this money. But we know, for example, with the war in Ukraine, a lot of the Globalfund funders are also investing in supporting that response. With COVID-19, we know a lot of governments in high-income countries are also supporting and investing in COVID-19 response and so many other things. So it's a very tight year, and the replenishment is happening in such a time when there are all these global health challenges. But we have certain opportunities where heads of state are meeting, and this is basically just the roadmap. For example, here in the region, we have an opportunity in June, later in June, because we are hosting in Kigali the Commonwealth Heads of Government meeting. And it's hosted in Kigali. It's going to bring Commonwealth Heads of Government, and it's an opportunity to amplify this in terms of what this investment would mean in terms of saving lives, for health systems, for pandemic preparedness, for helping us to get closer to the SDGs. Then we also have what we call the Tokyo International Conference on AIDS, on Africa's development. So basically, the meeting every 3 years where African heads of state come together with the government of Japan to deliberate on the agreement in terms of development support in Africa. So basically looking at how can we amplify the voice and speak up in support of the Global Fund impact and the importance of the Global Fund and what it means. So I won't go to any further slides. I think I will just reflect on why then it's very important for us to continue to think about not just the resource mobilization element of getting funding or grants from the Global Fund, but what are the other areas where you could have a stronger partnerships in terms of how health is delivered at the country level, how private sector come in. One of the things I had a couple of weeks ago is how it takes about $1 and maybe 20 cents to deliver one single mosquito net here in Kenya. And so the question is, and that's quite pricey if you think about the mosquito nets that we have to actually disseminate. So how can we, as a society, as partners, and with private sector, come together and push that to below $1? That's I think can also save us, something. And so many other things. We are talking about pooled mechanisms. We are talking about Africa Medicines Agency and how that pooling of production and commodities can help. So there are many things to discuss, and I just wanted to highlight that it is one thing, and it's very important to make sure that the Global Fund replenishment is successful, but also it's important to think about, in addition to the resources that come as grants, what are the other things that we can actually do? And one final reflection, I think we've also been talking a lot, we talked a lot on Monday on the first day, about local manufacturing, and I know we will hear that in the discussion. But I think one of the most heartbreaking things we are seeing is how you're having African states setting up local manufacturing so we can, generate local products, buy local, for local people. But when you even look at what's happening with COVID-19, you have all these incentives and interest, to actually do local production. But the biggest question is, about the market. So how can we also work with institutions like the Global Fund so that for the products that the Global Fund investment buys, can also buy them locally? If it's, for example, the COVID-19 vaccines or so many other products. So anyway, that's about the Global Fund in terms of the grants, and a lot has to be thought through in terms of beyond the grants, what else. So as we go into the questions and discussions, I'll invite Margaret, my colleague from the Kenya Coordinating Mechanism Secretariat, so we can do the questions and have a round of discussions. Welcome, Margaret.
Good afternoon, everyone. As you've heard, my name is Margaret from the Country Coordinating Mechanism of the Global Fund. I work at the Secretariat of what we now here locally call it the Kenya Coordinating Mechanism. Welcome, everyone. I know we have guests from the neighborhood: Uganda, Tanzania, South Sudan, Ethiopia. If there's anyone I've left out, please forgive me, but feel welcome. Now, to follow up on what my colleague has just presented, I'm not going to continue with any PowerPoints because I know you've been through enough. And what Rosemary has just given us is what we really need to help us move forward with this conversation. This conversation was born after the private sector, former private sector constituency. Like Dr. Nyalita said, the former private sector forms part of the constituencies in the country coordinating mechanism, which takes up the model of the Global Fund governance structure. I don't know how many of you are familiar with the Global Fund governance structure, because in the Global Fund governance structure, there's a board which has a chair, a vice chair, and 20 constituencies. 10 from the implementer block, countries like ours, that is. And from this region, when I say this region, I mean Africa, we have 2 constituencies. One is the Eastern and Southern Africa, and the other one is the West and Central Africa. Then we have others in Eastern Europe, Latin America, developing countries NGO. We have communities of people living with diseases. We have developed countries NGO. We have Eastern Europe. We have the Mediterranean region. Then the other block has the donor community. We have the America, we have Britain, we have the Norway, all those other countries in the Western Hemisphere. So for us to be able to do this, or to be able to be on this platform today as representatives or telling you about Global Fund and the replenishment, after the constituency engagement for the private sector, which happened in March, towards the end of March, we felt there was need to continue talking about this, and this was going to be a good platform because then we will get to hear also from the visiting countries on how they have taken forward or how they have been moving forward with this conversation in their countries, while we also talk about how we can come in to help with the replenishment and how we can improve the engagement between Global Fund and ourselves on this side. Not just to be seen as implementers, but we are also donors, because I know in the last replenishment, there are countries that on this side that contributed. Kenya is one of them. I think Kenya has contributed in all the replenishment cycles up to the 6th cycle. We have countries like South Africa, countries like Nigeria, and several others in Africa which have always contributed and honored their pledges. So our main task, myself and my colleague this afternoon, was just to actually get us to hear from you or the people in the room on how we can amplify or how we can move forward the engagement between our private sectors in our country, also as the federations that we have. I've just heard that one of the gentlemen sitting in front here is the chair of the East Africa Federation. Is there an Africa Federation? Okay. Okay, okay, that's okay, okay. Who chairs the Africa Federation currently? Ah, okay, okay, okay. So the Kenyan? Okay, that's good to know. So we also have the Africa Federation, and it will be good for us to just discuss that and hear from you. What is it that we can do to take this forward? Because with Global Fund, we've seen what they are able to do. Left alone as countries, we don't have this kind of resources, much as we would like to, but we don't have the resources to take care of our sick. So we always look up to friends who can come through for us in time of need. Global Fund did that for us, especially during COVID. And for HIV, TB, and malaria, they have been there with us for the last 20 years. So my assignment up here becomes very easy after the presentation, which was very detailed. So maybe there's some contribution or some questions that we can get from the floor. Yeah, they're getting your mic.
Thank you very much. Message well received. I'm from Tanzania. Unfortunately, my colleagues who are responsible for this are not over here in the hall. I'm totally from private sector. So exclusive private. That's my thing. But I'm also, I'm the immediate past Secretary General of AFTA. So I have little links over there, and we have indirectly benefited from this Global Fund. First of all, it is very difficult to understand the concept of global funding. And if that can be made very clear to the private, it would be very nice. The other thing is that how do you recognize as a global fund the public institutes for funding? How do you recognize them in funding? What projects would you be interested in? And what sort of grants can you give in uplifting and also be the partner to the public institutes? The other thing is the evaluation of the whole thing, the exercise that you do. I know there's a system whereby you evaluate the whole grants that you give. That we need to understand also as to how we can actually understand the evaluation of the entire projects or grants that has been given. Well, return on investment, it's quite interesting that you said 1 to 31. As a private practitioner, as a business, this thing, 1 to 31 would be something solid. I would just jump into it, put all my dollars there. But realistically, what do you understand, what do we understand by 1 to 31? If you can clarify on that, please. Thank you very much.
There's somebody on the right.
Hello, my name is Chris Muragori. The question that I have is, what is Globalfund doing to create more self-sustainability? Because I don't know whether it sits right with other people, but receiving funding for 20 years, are we going to say that we're going to receive funds, donations for another 20 years, another 100 years? What is the actual thing that is being done? Because if you look at the consumption of, for example, medications here in Kenya, it's really high. And if some of that money could be plowed back, some of these problems would dissipate. So my question is, what is Globalfund doing to self-sustainability? Thank you.
Good afternoon. Thank you for this presentation. My name is Dr. Anne Musuva from ThinkWell, which is a health systems development organization focusing on healthcare financing. My question is about participation of the private sector in HIV service delivery. Now, when you look at least here in Kenya, if you look at the proportion of services offered by the private sector, for just about all other conditions, it's about half, or at least 40%. Where the private sector is offering malaria, respiratory tract infections, whatever, all other conditions. But when we look at HIV specifically, according to a survey that was done by McKinsey, the private sector offers only 5% of HIV care and treatment services. And that's because the public sector offers the bulk of that. And what you find then is that there are patients who can actually afford to pay something, who still go to the public sector, and using resources that could be used for other patients and other things. So is this something that the Global Fund is thinking about, and what steps is the Global Fund taking in order to increase the participation of the private sector? This is in terms of service delivery for HIV care and treatment, because the private sector certainly has the capacity to do that. Thank you.
Hello, good afternoon. My name is Jacqueline Karachi. I work for Premier. My question is on the funding for pandemics. There was a part of it that you mentioned COVID-19, but you also mentioned other pandemics. My question is, how broadly are you looking at when it comes to pandemics? Our focus is on antimicrobial resistance, and when you look at the programs that you fund, HIV, malaria, TB, all those have an aspect of resistance, and I'm sure you're aware that we have a WHO mandate on, overall AMR resistance, and and efforts need to be made to curb that. So, is this one of the focus areas for Global Fund for now, or in the immediate future? And how can private sector potentially contribute to that effort? Thank you.
Yeah, thank you. My name is Steve, and I think my question is mainly what Margaret is saying. For decades, Global Fund has been there for infectious diseases, that's malaria, TB, and HIV. But by 2030, we're looking at a major problem, which is non-communicable diseases. Global Fund, the way it's structured right now, is quite siloed. How can we reimagine a global fund that's going to look at the patient in totality? I can't get good care for HIV, TB, and malaria, but the worst care for hypertension, diabetes, because I may be having both. So how do we ensure that we reimagine and reinvent how Global Fund can not just look at this three triple burden diseases, but we're looking at a patient in totality. How do we break those silos as we look forward to to SDGs? Thank you.
Can I suggest that we first try to discuss what has just been raised on the floor before we take the next set of questions, concerns? The first one is on understanding the concept of Global Fund.
I can get started on that, and Margaret, you can input. So thank you so much for that question, because I think it's important to understand the Global Fund model and concept, because then that can show you how you come in and what are the entry points. So the Global Fund partnership is, number one, country driven. So basically you have the Global Fund Secretariat, which sits in Geneva, but the determination of the priorities in which the Global Fund invests, so how it determines where to invest, where to put money, what to prioritize, comes from the country level. So at the country level, you have what we call the country coordinating mechanism. Here in Kenya, for example, it's called the KCM, the Kenya Coordinating Mechanism. In Tanzania would be CCM, and every country has that coordinating mechanism. That coordinating mechanism is a multi-sectoral platform. So you have the public sector there, so you have government sitting there and leading. The government is the leader of this platform. Then you have all the other constituencies. So you have the donor community sits there, you have private sector sits there, the communities and civil society sit there. And you have representatives. For example, I know within the KCM, there is a private sector representative who sits within that multi-sectoral platform. And so when it is time for a country to submit a funding request, because the funding is to countries, the partnership is with the Global Fund and countries. So it will fund governments, basically. And then within the country, we then decide what the priorities are. So when it's time to submit an application, the coordinating mechanism comes together, and there's a dialogue, there's consultation in terms of what the national priorities are, what is the disease prevalence and incidence, and so where are we going to put this money? And then as a country, we need to submit that proposal to the Global Fund. So we indeed, at the country level, government, all these stakeholders, this partnership is actually the one suggesting to the Global Fund the places and the ways to invest. And so maybe one of the connections with private sector is to connect with the private sector reps who sit on this mechanism, because they are there to bring the voice, the perspectives, the insights from private sector side. And normally what I've seen other constituencies do is that you would have a meeting ahead of that multi-sectoral meeting to agree as a constituency, what are your priorities? How are you pushing the discussion, and how are you supporting? So that's the Global Fund mechanism. It's really is emphasized that it be country driven. So the country decides the priorities, the country decides what to put in there, and makes the proposal to the government, which is why you see, for example, the Global Fund has to listen to the country in terms of how you want to procure your products and commodities, for example. Here in Kenya, the government recognizes KEMSA as the main agency for procurement and supply in the country. In other countries, they have other institutions, and the Global Fund does not determine that. So even without getting into greater details or into an in-depth, that is, I think, just a quick overview and, I guess, insight into how the model and the partnership looks like. There was, Margaret, shall we look at sustainability?
Thank you, Rosemary, because in your response, you've actually addressed more than one question. There was the issue on disease patient, looking at the disease of the patient in totality, that was asked by, and you heard that it is country-driven. So what the country sends out, we send out a proposal. What we send out to Global Fund is what Global Fund responds to. And mostly it is what is contained also in our strategic plans, especially for the 3 diseases. But I know even beyond the 3 diseases and beyond COVID, we've had where Global Fund has supported, even though she was asking in research, there's a lot of support even in research. I think they even have something that they're supporting now with Cambridge, together with the regional grants, EXA and others are also getting some money on research. Then also we have reproductive health also is supported big time, because there's a lot, when you look at malaria, when you look at HIV, you don't look at them in, by isolating the other disease, some of the things that are closely related, like reproductive health. So I know there is that support. So Rosemary has actually responded to more than one question.
Just to add one thing, small thing, Margaret, to that question also, when the Global Fund was coming up with a new strategy, there was consultation and asking stakeholders and partners, would you like to expand the mandate of the Global Fund beyond now the things that Margaret has mentioned, to include even broader things like, what you are talking about, hepatitis and all that. And throughout the consultation, there was consensus that the Global Fund needed to keep its primary mandate to HIV, TB, and malaria. And actually, and also, with the health systems and pandemic preparedness, the Global Fund sees that health systems and pandemic preparedness is an entry point through which other disease areas could leverage, that investment. If you invest in health systems, in pandemic preparedness, basically, which means supporting healthcare workers, buying some of the commodities, you're actually expanding the capabilities of the health system to even respond to other things. The opportunity to reflect again on the mandate will come after maybe 2026, when the Global Fund will be developing its next strategy.
Mr. Kamau, thank you. I'll give you an opportunity to expound further on what we are. There was also a concern raised on what is GF doing to create self-sustainability. Is this for countries or for GF? Yes. So I'll have Kamau respond. He's on the floor. I'll have him respond to that on the issue of domestic resource mobilization. And also Global Fund has, as Kamau starts, for most of the countries, actually all the countries that receive Global Fund money, Global Fund insists that there is a core funding. So that's one of the steps. From 15%, but it also depends on the level at which the country is economically. They are the low-income countries, low middle income and all, because now Kenya stepped up. So the ratio is higher than probably what you'll find in some other countries in the region. Right now for Kenya, it's about 20%. Yes. of the total GF funding. So they have to give in 20% of that before that money is released. And the government has also been increasing. This does not include what the country pledges for replenishment. So there is what the country will pledge for replenishment, there is what the country gives in for core funding, and there is also what the country puts in its budget for the 3 diseases. So countries are encouraged to continue increasing that. And while we are at these, we have also, like, because of our structure now, our governance structure in the country, we have counties also increasing their contribution towards the 3 diseases. I was in one of the counties this week, and whatever they are contributing is tremendous. So that is one of the areas. I'll let also Kamau say more on it.
Thank you very much. My name is James Kamau, and I just wanted to answer. Oh, it's gone, but I can. No, on sustainability. One, let me address the first one, which was on the issue of the private sector, where there's about 5%. Yes, it is out there, and a lot of those people who go to the private sector is basically because of privacy and the stigma involved. But out of that 5%, a lot of them are coming back now to the main comprehensive care centers, because those centers have the experience within which to look after the disease. Now, looking into the comprehensive care centers, and this is the advantage about what Globalfund has helped in developing the CCCs, or the comprehensive care centers around the country. When COVID came in, it is that system that is lying there that they took, that was taken, so that it could deal with the issue of COVID. So ideally, it also helps in the health systems of the particular countries. There was another one. Remind me the last one. Sustainability. Yes, in terms of sustainability, I can comfortably tell you in Kenya, we've came up with a roadmap, which was of a team that made up very high in terms of transitioning from donor funding to domestic funding. And it has been accepted at cabinet level, and it is going to go, because like you've been told, Kenya is now a middle income country, so they need to put much more, and the amount of funding that they were getting comes down. And yes, it is also important for countries within to understand that Globalfund helps, but the country also needs to put into place measures of how they will take over, because it will not always be there.
Are we okay so far? All the people who raised questions or concerns?
For monitoring on Globalfund, that's what he's asking.
Program level, country level?
Yes, country level, or even at the association level.
At
the private patient level.
Let me start by first again saying what, I'll just repeat what Rosemary has said. The Globalfund model is such that they don't have in-country presence. Instead, they have what they call a country coordinating mechanism. So the coordinating mechanism provides oversight on all the grants, all the money that comes, whether it is being implemented by the private sector or the non-state actors. For example, in Kenya, money comes in through principal recipients. One is the government, that is the National Treasury. Then we also have Kenya Red Cross as a non-state recipient, and AMREF Health Africa as a non-state recipient. And if I'm not wrong, AMREF and Kenya Red Cross are all members of the Kenya Healthcare Federation. So you see the private sector is still playing a role in implementation of Globalfund in the country. So all those three principal recipients are oversighted by the country coordinating mechanism. The country coordinating mechanism at the country level takes up the structure of the Global Fund. There's representation from government, donor community, communities of people living or affected by the three diseases, especially when it comes to malaria and TB in Kenya. The people who sit at the country coordinating mechanism are people who lead organizations that carry out TB work or malaria work, but we have the networks of people living with HIV represented in the country coordinating mechanism. Then we also have the key population. The key population in the country coordinating mechanism has a representation from the MSMs, the FSWs. Then we also have a constituency of adolescent and young persons. So, and we also have the faith-based organizations sitting in the country coordinating mechanism. The Kenya coordinating mechanism has got 23 seats, and each seat, that is a vote. And each vote has an alternate member, such that if the member is not available, then the alternate sits in. There is no time that a decision can be made without any of these constituencies being represented. So you find that it is very, very represented, and it has a wide representation because of its flexibility. Currently, I think in the health sector, the CCM is the structure that has that kind of representation, which is being, I was talking to somebody just before we started, and he was telling me it's being replicated even in some of the state corporation boards.
I'm sorry, I apologize that it would be our executive director who would know the mechanics of Global Fund and Uganda and the specific details of that, because that's what the secretary would be involved in. But quite recently, now within the last couple of years, as far as HIV funding was concerned, there was an edict that the private facilities could no longer access the medications. They're distributed through the joint medical store. I forgot the name of that thing.
KEMSA.
KEMSA. Yeah. So I thought that was quite a retrograde step, and that was Global Fund decision, because I think the funding for the drugs comes from USAID as well as Global Fund. But I thought that there is for example, in my own hospital group, we had to devolve the distribution of HIV drugs from the hospital itself and the clinics themselves to an NGO which we have associated with the hospital. So it was more of a bookkeeping exercise in some ways, but I didn't see the sense in that. And if you want to antagonize the private sector, obviously say, oh, we're not going to trust you to actually give out free HIV drugs. But as I say, that's probably way below where you're at, and you probably don't know. I apologize, my executive director's not here. She could give you more details on that.
If I understood well, what you're talking about is the engagement of private sector in distribution of ARVs. Yes.
It was actually, they told us to stop doing it. You must hand it over to a non-profit or a faith-based. Didn't make any sense.
Government to the private. Yeah, but I think if I get you wrong, I'm getting you right. Even here in Kenya, we have private hospitals that have comprehensive care centers and receiving money from Global Fund, and they're giving out. So I don't know whether that is what happened.
It was actually the supply of the drugs. So you would have we had, I think we had about 800 patients. So the patients are getting the drug through your clinic or through the hospital, which is private. But the drugs are supplied by government, or not by that mechanism that distributes distributes the ARTs. Okay?
That's what I'm telling you. Even here in Kenya, we have private hospitals.
Yeah, but they stopped it in Uganda for some reason.
Okay.
Maybe what I could ask you to ask your executive director to do is contact NASCOP, the National AIDS STDs Control Program, and engage further so that probably there are new guidelines. And I remember there is a time the supply of ARVs was not very consistent, so they will first concentrate on public hospitals and all. So maybe just ask your executive director to contact NASCOP. Is that okay? Do we have another? Yes, somebody there.
Thank you. I'm Douglas Onyancha from Africa Resource Center. I wanted to respond to his question. What I know is that in Uganda, there's currently a pilot going on where the private sector is actually distributing or rather dispensing drugs. So what happens is that the private facilities are linked to a public facility. So the drugs actually come from the public facility hospital to the private or retail pharmacies from where now the patients pick. So I know that has been piloted, but it's not been rolled out up to scale. But those are discussions that are going on because, and I'm privy to it because our organization is actually leading that project. Thank you.
Thank you. My name is Odoro Tieno. So mine is not really a question, Margaret, but mine is just an insight. And I borrow this from what Professor Rogo shared with us yesterday, that when you look at the county, the departments for health or the county government structures, for example, they are not really failing at devolution, but what's failing them is the mechanisms to disburse funds, whereby you find that a whole quarter goes through before that quarter's fund has been disbursed. So why am I bringing this to KCM? When you look at the KCM structure and the whole process of grant evaluation and assessment, you find that there's usually that space, that lag of time through the contracting process. By the time the implementing agent or the sub-recipient hits ground and starts implementing, you find that a whole quarter or two or so has been exhausted within the funding cycle just through the contracting process. And it's good to see that we are in May 2022 and you already have the strategy for 2023-2028 discussing it and tying the loose ends. I would wish to see a scenario whereby KCM locally gets in a mechanism to evaluate the grants or the fundings, the proposals way earlier March, so that by the time the granting cycle begins, whoever has been given funds to implement can hit the ground running. Because what happens is that with the current scenario, you'll end up with only, let's say, 18 months out of 24 to implement within a constricted time frame. And with that also, the sub-recipients or the recipients now play catch-up phase in terms of burn rates. And that basically doesn't move us towards the outcomes that we desire. So basically, just an insight, not really a question. Maybe you can respond to that. Thank you.
Thank you. Can I request that now we move on to the private sector and GF at the global level?
Sorry, at the global level or country level?
Just say that again. Okay, just ask. I can give you a chance because you are not from Kenya. I wanted to move away from Kenya. No, you are not.
Okay, just want to say a couple of quick things. Let me take off one hat and put on the other hat. Well, actually, the old hat. In the old hat, I was actually the alternate member for the Global Fund as well, in the CCM in South Sudan. So, I actually did work a lot with the regional body with IGAD as well. But at the same time, to answer his question on sustainability, Global Fund is supposed to be a gap filling. So it's not supposed to gap filling funding model. So it's not supposed to fill to actually buy all the ARVs, all everything else. That's supposed to be the role of your government or your respective government. And if there's any shortfalls in here, that's where they're supposed to come in. Coming in, thinking now as a private sector person, one of the biggest challenges with the Global Fund, and it's always being not utilized properly or not focused on, is logistics, especially in-country delivery models. That's where your inefficiency comes in. That's where a lot of cost comes in. That's where pilferage comes in. And there are many ways. In fact, I was, over the last couple of days, just being here alone, there's so many IT systems that can be used to track. And I think you need to actually come up with KEMSA on to find better solutions on making your last mile distribution. Because I don't think you're a stranger to the fact that every so often there's news coming out on the newspapers and everything else of HIV drugs being stolen from KEMSA. Of course, they say KEMSA is as open as a church. Anything can disappear from there, but anyway, that's another story. So you have to find ways to be more efficient, to maximize on whatever little you have. And until you do that, then you cannot manage a bigger grant or whatever, because you'll still have the same problems repeating themselves. That's on the logistics and last mile distribution. Engaging private hospitals, and to support with the ART facilities from clinics and everything else. That will be good, especially in the grassroots and in the regional areas, because due to stigma, which is more prominent in remote areas than in cities, for example. And in that case, you have to now think out of the circle a little bit. Now it'll come now to the CCM to work on, let's say, performance-based incentives on how you're going to give these people something and get their reports back. And it's good that you have all the reporting systems in place with DHIS2 in Kenya and being operated. So it actually helps you get the data, keep your targets, but at the same time, provide the services on the ground level. So that covers training and everything else. I had a chance also to travel to Rwanda and visit and see how they're doing their work on that side. Private health facilities were being given, let's say, mosquito nets and mosquito coils and lotions and everything else to distribute at a reduced price. So they actually buy it at a reduced price and have a margin for it. So which helps with the eradication of malaria, but also helps with their profit margins and everything else. There was a pilot that was being done in some of the areas in terms of having a subsidized cost of malaria diseases and everything else. If you look at that, let's say there was the pilot of having Coatem and everything else being pumped through the wholesalers, which actually worked, but unfortunately it worked at the wholesaler level. It didn't actually go that much further to the retailer level, whereby the recommended price was not being stuck to. So this is something that has to be adjusted accordingly to make sure that the drugs are actually available, for example, in terms of malaria, and easily accessible to most of the people. In manufacturing, I think there's only 2 companies that do manufacturing who are Global Fund accredited in sub-Saharan Africa. And that's CIPLA and whatever in Luzira, Kampala, and Universal. These are only 2, I think. Unless I'm wrong, Dr. Ian. But these are the 2 companies that are accredited. WHO accredited, and also on the list of Global Fund companies who actually can manufacture ARVs and antimalarials to the same quality that's expected. Thank you. And with that note, if you can take advantage of that, you cut out on logistics. You cut out on logistics and lead time, because It takes less time to get from Kikuyu than it is to get it from India.
Thank you. That was more of an advice, it was more of sharing of experience than a question, so maybe we move on. Is there anybody else with anything?
Yes, right here. So my name is Kenneth Masharia. I'm the country representative for Options. Options is a global firm that works in the health sector. So question for you in terms of how you're coordinating homegrown resource mobilization with the funding that you're sending out. So for example, in Kenya, there's a lot of work being done at the county level to generate resources at source, right? Or at delivery point. I'm just wondering to what extent the funding that you're rolling out through the Global Fund is actually linking into that. And then my second question is, you say that there's a lot to do or advocate for around the replenishment. What are you asking for? What do you want us to do? Thank you.
Yes, please.
I asked the question again. Okay. So the first question was around on-source revenue and how we are linking in the investment coming in from the Global Fund at a country level to amplify what is being generated or being put in by the government at the country level. Then the second question was, you're asking about you're moving towards a replenishment. The question is, what do you want us to do? What help do you need from us as global players? We work in over 50 countries, and so the question is, to what extent do we plug in? How do we plug in? How do we support you towards that particular goal? Thank you.
I think question number 2, Rosemary will answer you. The other one of the ratio, do I get it? Is the question of the ratio of how much the government is putting in vis-a-vis. Sorry? A catalytic. Yeah. Okay. That has been used, and I think one of the things that is happening, it is the Global Fund has been able to help the systems, the health systems within the country, for them to be able to put them together. So not only for HIV, but for the whole health system, which is into place. And I think it's important because at the end of the day, issues like the efficiencies, the opportunistic infections and others are the same everywhere. How do you get them and how do you use them? And the reagents are different. So I think it has helped catalyze that. And that is why it has helped the governments, especially the Kenyan government, but I know even the other, to be able to see the return on investment in health. And I think that is what has been there. Rosemary?
I can add, you want to add that, eh? Okay, so.
Maybe to also add on to what James has said, we have had emerging concerns, I would say, because previously, even when we started responding to these diseases, especially HIV, we were looking at it in a straight and narrow, where we were looking mostly at HIV care and treatment, and it was all facility-based. But with the help of Global Fund, we have been able now to work even with communities, not just to look at care, at treatment, but also to look at prevention. We've also had Global Fund resources catalyze governments, and not just in Kenya, in the implementer countries, get them to respond to issues of human rights and gender. And especially now, and after the COVID 2 years, we've had a lot of GBV cases. So there's what we are even calling now the triple threats, because through the issues that are going on in homes or even in communities, there has been an increase in HIV infections. And therefore, things that previously probably the government was slow at because we were doing everything as facility-based, you find that now the government is also getting into other areas that ordinarily they were not, working with law enforcers just to sensitize them on what needs to be done, whether it is okay to arrest somebody because they are, an MSM. The IDU, they remember the drug users. The drug users for the longest time were in hiding, but with Globalfund help, we were able to convince communities that these people need help. They're just as sick as the other person. So we are able to come out and protect them. Even when they are arrested, we have a way of going to say, no, this is one of our own, and they are on the path to recovery or to getting away from using drugs. So there's a lot that has been done, and including health systems, improving health systems. So you find that now we have, maybe in some counties especially, you find that almost at all levels, facility levels, we have youth-friendly centers. I was impressed to hear the other day, I think it is in Isiolo County, they're considering having a discordant couples center, which it's just one way of also attacking this spread or reducing stigma so that people can access services. So there's quite a bit that is going on using Globalfund as catalytic investments.
And that's a really, really good question, because we also always ask ourselves, because it ties to the question of sustainability. The question of Globalfund is investing, but are we in an incremental way also finding ways to generate resources locally? And I think the fact that the Globalfund requires the country to commit to the core financing at the stage of the grant application by actually submitting a letter of commitment is one of the mechanisms, because also the way the money is triggered if you as a country has fulfilled your obligation for your domestic financing. I remember one time, and I know it's not right to mention countries, one time Zimbabwe was struggling with stockouts. And when you go to the back of that story, it was a stockout because there was a challenge with the core financing at the country level. Because the Globalfund really wants the country to step up, to say, your core financing was the share that was supposed to procure A, B, C, D. So really encouraging the country to say, yeah, we are giving a grant, but this is your share. This is what you're supposed to put on the table. So I think in that way it helps, and I think a lot more needs to be done, but it really helps to trigger and to spur. And I think in the long term, to prepare countries with systems that can begin to build muscles that can stand on their own. In terms of the replenishment, what are we asking? So it's a time when there is a lot going on at the global level. The Globalfund is not the only global health financing institution that needs money. The World Bank was doing their IDA replenishment. The Global Financing Facility, they're just winding up their replenishment. Gavi is just winded up their replenishment. So there's all these global health institutions with their multiple replenishment. But what we are asking is if we can recognize the importance of the Globalfund, the impact of the Globalfund, and be able to speak and amplify that in spaces that can influence decisions. Right now, a lot of the donors are struggling with resources, because there is Ukraine, there is COVID, there are multiple replenishment. But we want to talk about the impact of the Global Fund. We want to be able to speak to why the Global Fund is unique. And actually, all the other systems are very important. Gavi is important. GFF is important. World Bank is important. But this moment is for the Global Fund. So it's really for us to look at the spaces where we can influence decision-making. So if we can be in spaces where we are talking about the value, the importance of the Global Fund. Now, what are those spaces? Those spaces include, do you have connections, for example, with the UK Embassy in Kenya or the British High Commission? Do you have diplomatic engagement, relationships with some of the donor embassy countries, donor country embassies here in Kenya? That you, or even outside, because a lot of you here are global players and regional players, because when they hear the demand from the country level, that there is impact, the Global Fund supports health systems, the Global Fund supports ABCD, then that information message can get to the headquarters, and then the headquarters can make the decision. And so that's one of the mechanisms, and that's one of the asks. Now, the other thing is that many of you sit in positions of power and influence. Maybe you belong to a technical working group somewhere, at the Ministry of Health, Ministry of Planning, somewhere you have a circle of influence. And so if you can put a good word that goes into supporting the Global Fund, talking about the impact, the importance, and also the cost of inaction. Like if we don't get the 18 billion US dollars, what is it? What is the cost of inaction? And talking about the investment case, like it's going to help save 20 million lives, etc. Those opportunities, apart from the embassy opportunities, are also there because I was talking about the Commonwealth heads of government meeting that is going to be happening in Kigali. Every country here is going to be sending a delegation there. If you know people who are in the delegation, if you interact with them and send them with this message that when you get there, one of the things we want to see in the outcome document is support for the Global Fund, support for HIV, TB, malaria. And we are also engaging there, but I think what we need are numbers, what we need are more voices in this evidence. So there are many, many other opportunities. There's going to be the UN General Meeting later in September. I know there is the Tokyo International Conference on Africa's Development, which all our heads of states are engaging and participating. This is mostly with Japan, and Japan is also one of the biggest donors to the Global Fund. So it's really about understanding the value of the Global Fund in the country level, and also recognizing how it contributes to sustainability, which is very important, as we have mentioned. So if we get it funded, replenished, it means we have another 3 years to continue to strengthen health systems, to continue to catalyze domestic resources, to continue to save lives. Yeah, thank you.
There's somebody. Can I now just say we take one last one, so that there's another program starting at 4 o'clock.
May I add something from AMREF? I just wanted to contribute that in terms of sustainability, what Global Fund has done, the funding that the Global Fund brings to the country, exactly more than 19% of that funding is geared towards resilient, sustainable systems of health, where we are doing a lot of capacity strengthening, both at health facilities and also at community level. We are doing a lot of capacity building on community-led monitoring, community-led advocacy, and research. And this is towards, Global Fund has put a lot of funding towards sustainability in terms of whatever gains we have made, that they are sustainable and the systems are put in place to ensure there is continuity. That's very important. The other aspect that I wanted also to bring up is the issue of particularly the funding that we have received on COVID, where we are procuring a lot of commodities for oxygen. We realize there's a low burn rate in the sense that majority of the things that we need to procure has to be procured outside the country. And hence we are having a lot of challenges burning that money. How about the private sector coming in and, just as one of the speakers has mentioned, homegrown solutions, homegrown resources. We are having like right now, a challenge with cartridges in the country. You go all over, we are postponing most of the activities because there are no cartridges because of monopoly. One person just producing this, the cartridges CFID. How about having a homegrown solution? Because now people are reverting back to testing, particularly tuberculosis, through microscopy. I think that we had surpassed and we are now using Gene Expert. How about coming through and looking at some of the commodities that we are now procuring through WAMBO, getting a homegrown solution? How can we bring this back home so that we have private sectors in the country providing some of these commodities where we are floating tenders and they go unresponsive because we don't have people who can supply the commodities that are there. That is how we can also tap into the resources that are coming into the country. Thank you.
Thank you, Amref. I'll allow this gentleman who's holding a mic.
Yes.
Be our last one so that we allow this function, this whole expo to end as they had envisaged.
Thank you. I'm Job Ndege from SafeAid. She has just mentioned SafeAid. About the core funding, I had a question on that. I know that Global Fund supports various initiatives. We talk of TB, we talk of HIV, we talk of malaria. Now, when the government of Kenya is co-funding 20%, like Mr. Kamau was saying, is it per initiative? Is it per program? Or is it just on the general pot that Global Fund gives X, the government gives 0.2 of X? How does that work?
The co-funding percentage is dictated by the amount that Global Fund is giving and also the category at which you are economically. I had said that earlier. So Kenya is middle income, so ours is 20%. So if you're getting 10 million from Global Fund, 10 million US dollars, then 20% of that. So I want to thank all of you. And for people like, what is the organization, this gentleman who spoke last? Yeah, maybe you can talk to me after this so that I advise you on where maybe locally you can engage so that we don't hold everyone else. I know private sector had requested that we end these at 4, or rather the organizers had requested that we end these by latest 4. Yeah. In case you have anything on local issues or whatever, please just feel free to reach out to me. You can talk to me. Any other matters on replenishment, you can talk to my colleague Rosemary. Thank you.
Thank you so much, and the wonderful session. There was a few gifts that were here. I'd like to present them to, if they're still here. We have Emmanuel Togun.